the macula is the central part of the retina. It's the area of the retina that's got highest visual acuity. So it's where all of your conscious vision comes from. And at the very center of that macula is what we call the fovea, which is an area of the retina that's extremely thin, but it's the area that gives you the highest acuity vision. So it's what allows you to have reading vision and to thread a needle and see those really fine details. The problem is that the retina is very thin there and very fragile there. And so there's a few different things that go on in macular hole, and there is a little bit of debate as to the exact mechanisms that cause macular hole. It's probable that there's a few different things that can do it. We know that one mechanism, and we know that because we see it in patients that we watch over time, when the vitreous is starting to detach, when that process of posterior vitreous detachment is happening, there are some of us that, for whatever reason, have a vitreous that's just a bit stickier than it should be. And so instead of coming cleanly away from the retina, it can stick in one particular area and pull on the retina as it lifts away. Now, if that happens out in the peripheral part of the retina, that's how you get retinal tears and potentially retinal detachment. But if that happens over the macula, then as it pulls away, it can cause something called vitreomacular traction, which we'll talk a little bit more about later on. But if all of that traction is concentrated right at that very central thin part, the fovea, then as the gel comes away, it can actually pull a hole in that thin area of retina, and that's what we call a macular hole. And so when a hole happens out in the peripheral parts of the retina, that's not an area that's useful for vision. So it doesn't cause any problem with vision in and of itself, but it can cause the retina to detach because the hole in the peripheral part of the retina can allow fluid to track in underneath the retina and cause it to detach. In the macula, the hole in the middle of the fovea, that is an area of retina that's useful for vision. And so when you develop a hole in the macula, it affects the central vision. And so what patients will notice is that they'll be able to tell it's maybe not the split second it happens, but generally over the course of that day, they'll just suddenly become aware that the vision just doesn't seem as clear in one eye. And if they go and check with one eye, maybe check their Amsler grid, they'll notice that they've got a blurry patch in the very center. Sometimes they just describe it as a little area of blur, and as it gets bigger, they may see just kind of a grey blob in the center of the vision where they know there should be normal vision at the very center. There's just an area they're not seeing very well, either blurry or grey. And that's because of the fact that a hole is formed in the retina. And because the macula is like the film in the camera, if you develop a hole right in the center of the macula, it'd be almost like making a cigarette burn through film in an old analog camera. That no matter what picture you take, there's always going to be that hole in the very center.
Okay. And so, how do you treat it as an ophthalmic surgeon?
So, macular hole is. It's one of those conditions that really needs urgent treatment. So, something like a cataract decreases the vision, but we know that as soon as you have that cataract operation, the vision will be back to where it started. Whereas with a macular hole, the longer we leave it, the more damage is occurring in the tissue. And so the longer it's left, the less likely we're going to get back to normal vision. And in fact, the hole forming in the first place generally means that eye is never going to be quite as good as it was before the hole happened. If we get in there really early, we can get it back to the point where the vision is very, very good, but you can generally always tell that eye is not quite as good as the other one. So unfortunately, some of that damage is just not something that we can repair at the moment, but we need to get in there ideally within, so the international guidelines say that, we should be aiming to get the operation done within about 4 weeks of onset of symptoms at the absolute maximum. And the earlier we do it, the better. And so within the realms of safety, because, we don't want to be doing very fine detail surgery. We don't really want to be doing this in the middle of the night when everyone's fatigued and we all need our concentration. So it's a balance between getting the surgery done safely, but also doing it quickly enough that we're not allowing more damage to occur in the back of the eye. And so it is a condition that needs an operation, and that operation is what's called a vitrectomy. So vitrectomy means removal of gel from the back of the eye. It's removal of the vitreous. And so if I go back to our eye model, it's keyhole surgery. So we make tiny little cuts in the white part of the eye towards the front. And that allows us to pass little instruments into the cavity of the eye in the back to remove the gel and work on the retina. The incisions made for this are basically needle puncture incisions. So most of the time, our workhorse instruments for this are what we call 25 gauge instruments. So if you imagine for anyone who's familiar with needle gauges, 25 gauge is absolutely tiny. It's smaller than the needle you get your vaccinations through. And we've got instruments small enough that we can pass through those little ports, remove the gel, and then remove what we call the internal limiting membrane, which is the surface layer of the retina. It's not a cell layer. It's again another connective tissue layer, but the reason the macular hole remains open is because of scarring that forms in that internal limiting membrane. So that membrane has these scarring forces that are holding the hole open. So by removing the membrane and then putting a bubble of gas in the eye, where we remove the forces holding the hole open, and the gas bubble helps to gently push the edges of the retina back together to seal the hole. Because the retina is extremely sensitive tissue. We really don't want to be touching it directly or manipulating it directly because we can cause damage. And we're talking these holes. We're talking about holes that are usually anywhere between 50 to 100 microns in size and 400 microns in size. In fact, we would consider a very large macular hole to be anything bigger than about 400 to 500 microns, which is half a millimeter. So we're talking very fine detail stuff here, which is why we need such small instruments and why we want to be being as minimally invasive as possible.
Okay. Now I'm a little bit confused about something. From my reading, when I've read about the recovery process after this type of procedure, some say that you have to remain in a face down position, and then others don't say that at all. So I'm just wondering, like, what does the recovery process look like for macular hole treatment?
So look, a big part of this depends on how big the hole is. So like I said, the key part of the operation is removing the internal limiting membrane and then putting this bubble of long-acting gas in the eye. So we usually use a gas called sulfur hexafluoride, SF6, and that's a gas that stays in the eye for about 2 weeks. So the gas is put in as a bubble in the back of the eye where the gel was, and over the next couple of weeks, it gradually dissolves into the bloodstream and is removed by the lungs. You just breathe it off in your breath, and that allows the eye to slowly refill with the fluid that's usually in the front chamber of the eye. The gas bubble, so we do want it to hang around for at least a few days because that's what's helping to push that hole closed. So once the operation's done, we need the gas bubble to sit in contact with the macula to help create that surface tension and that pressure that's going to try to push the hole closed. And because this is a bubble of gas, it floats on water. So by going face down, we're ensuring that as the bubble floats, it sits against the macula. So the instruction for just about everyone who's had this operation is you're going to be face down overnight. So that means for the first 12 to 24 hours, you're laying down either with your arms crossed over your forehead or with a pillow under your chest so that the bubble sits properly against the macula. Depending on the size of the hole then depends on how much longer you need to be in that position. So again, this is an area of active research. So if you go back 10, 15 years or so, the advice was generally that you needed to be face down for 3 days or 5 days, sometimes even a week, which was just intolerable. So when they actually studied this, they found that even patients who were doing their absolute best to stay face down for a week were only probably managing to do it for 40 or 50% of the time, sometimes less, because it's really difficult. So these days, we're more likely to say, look, face down for the first night, and then for the next 2 or 3 days, sitting up in what we call reading position. And so that's sitting up but facing the floor. So you imagine if you had a book in your lap and you're looking down trying to read it. So I usually tell my patients, all right, so the first night after surgery is going to suck. You're going to be face down. It's going to be miserable. You're allowed to get up and go to the bathroom. You're allowed to have a 5-minute break now and then just to stretch a little bit, but really important that you face down for that night. You're not going to get very much sleep. I'm really sorry. Blame me later. But for the next couple of days, I just want you sitting up and looking between your toes and the skirting board. And as long as your head's in that kind of position, the bubble's still going to be sitting against the macula well enough that it should be able to close that hole. And most surgeons will, these days adopt that process where you're only really doing that for about 3 days or so after surgery. And that's because the studies are showing us that anything longer than that probably isn't doing very much.